Okay, so today we'll be talking about Ceritinib, frontier in the first line management of ALK-positive NSCLC. The slides have been provided by Novartis. So NSCLC is a heterogeneous set of diseases defined by lots of oncogenic drivers, and as far as ALK mutation is or ALK rearrangement is concerned, we see around 7% of patients who have ALK rearrangements. They tend to be young, they tend to be never smokers or a light smoking history. And the important thing is ALK-positive tumors have a tendency to metastasize to the brain. So either it can be upfront brain mets in maybe around 30% of patients, or you can have a relapse in the brain. So maybe in the lifetime of ALK-positive patients, you can develop up to 50 to 60% of times brain mets. So that is the main issue with ALK-positive tumors. If we look at, on the right side, if we look at metastatic lung adenocarcinoma, a 5,000 patient analysis, you can have potentially actionable driver mutations in a lot of patients, and that is why testing is important. So when we talk about testing, Dr. Aparna has already gone through all of this. FISH, PCR were the conventional forms of testing. For ALK-positive tumors, FISH was considered to be one of the gold standard. ALK is interesting because ALK IHC on a Ventana platform D5F3 clone, that is also considered diagnostic, and that you can treat on the basis of IHC. So that is one mutation in lung cancer which can be treated on the basis of IHC report alone. But nowadays we are moving towards NGS and DNA and RNA analysis. The reason is when we have a tumor biopsy with subsequent analysis, so IHC we usually do TTF1 napsine for adenocarcinoma, EGFR for ALK if we do a IHC and then a confirmatory FISH, etc. So PCR, IHC, etc. Then you sort of lose the tissue and we do not get the desired results. So one patient and one multi-gene test, which is recommended by both NCCN and ESMO. And so NGS is the way to go, and it was heartening to hear that in Tata especially the turnaround time for NGS is as low as 5 to 7 days now, so we get a report very quickly. But if we are suspecting a ALK-positive tumor, 1 to 2 days IHC report also comes, and that is something which we can consider, especially if you have a patient with, say, a front dissection of a brain mets, you have reasonable amount of tissue, IHC can be done as a rapid screening test for ALK. Benefits and challenges of NGS panels. Challenges are cost, technical challenges, accessibility, and potential false positives, along with the turnaround time, but that is decreasing. But benefits are many. Up to 3 times more clinically actionable alterations are seen with NGS. And NGS panels may provide data on all known mutations for targeted therapy, and also may provide data for other alterations like you saw STK11, KIP, etc., which might sort of predict resistance to the standard treatments like immunotherapies. Novartis has been kind enough to support us with coupons for multi-gene testing like these 15 genes along with the PDL1 IHC. Now we talk about Ceritinib, and this is the ASCENT-4 study in which Ceritinib was compared with pemetrexed platinum-based chemotherapy in ALK-positive NSCLC. So this is a very simple sort of trial design. Nowadays we have a lot of complex trial designs. ALK-positive tumors, first line, 1:1 randomization, Ceritinib, 750 milligram in this study. It was used in fasting state, 750 milligram, compared with pemetrexed platinum-based chemotherapy. For patients receiving chemotherapy, you had the option of pemetrexed maintenance. And there was optional crossover, around 80 patients did undergo crossover, and stratification factors were performance status, brain mets, and prior neoadjuvant or adjuvant chemotherapy. The primary endpoint was PFS, and there were multiple secondary endpoints. So this study was positive. Ceritinib did meet its primary endpoint. The median PFS was doubled as compared to chemotherapy. Median PFS was 16.6 months versus 8.1 months. Hazard ratio of 0.55 translating to a 45% reduction of progression or death as compared to chemotherapy. Overall response rate was 72%, duration of response was around 2 years, and 24-month OS rate was around 70%. If we look at the Asian patient subgroup analysis in this study, there was again a 34% reduction in the risk of progression or death. So the drugs did seem to work in Asian patients also. The issue with 750 milligram dose of Ceritinib was GI toxicity. And I would like to actually commend Novartis to actually have this study which has tried a lower dose with meal, because usually we always see many pharmaceutical companies trying to for the higher maximum tolerated dose rather than a lower dose, so as to speak. So this was actually something different, and they did this 3-arm study with Ceritinib 450 milligram with meal, 600 milligram with meal, and Ceritinib 750 milligram under a fasting state. And the primary endpoint of this study was not survival, so as to speak. It was just the pharmacokinetic data of 450 versus 600 and 750, and there was no clinically meaningful differences in the steady state PK of Ceritinib between 450 milligram fed and 750 milligram fasted state. But more interestingly, you are seeing here these three sort of plots, and you are seeing in the solid red line 450 milligram with meal. The orange is 600 milligram with meal, and the dotted is the standard dose which was used in Ascent 4, that is 750 milligram fasted. And here you are seeing that actual benefit in terms of the PFS OS is more for the 450 milligram with meal curve, with meal arm. If you see the response rate in the top row, 80% response rate across the board. But if you see down, the median PFS rate at 24 months, 450 milligram fed state, 58.9 versus 37% in 600 milligram fed versus 22 only in 750 milligram fasting. And also the OS rate numerically, these are very small numbers, 20 to 30 patients, but 93% at 3 years versus 62 versus 70.9. So basically, not only was the drug tolerated better, not only was it financially more viable because we use less amount of drug, but also the survival was improved. Even with these small numbers, you can see that the survival was improved. And that is the standard dose which we use nowadays in our practice. Another thing is ALK-positive NSCLC, like I said earlier, 30% may present with brain metastasis, 70% without, and during the course of illness, many patients do recur in the brain. So 60 to 70% of patients may recur during the lifetime, and obviously there can be issues because either the tumor becomes resistant to the drug, or there can be pharmacokinetic differences like Crizotinib, which was the first ALK inhibitor which was approved. Probably the penetration or the concentration into the brain is less, and there is a significant proportion of patients failing in the brain. So CNS was the primary site of relapse, 46% of cases in progression with Crizotinib. And CNS relapse, obviously it's difficult to tackle and also causes a lot of deterioration of quality of life. So in treatment of ALK-positive tumors, prevention of CNS relapse and decreasing intracranial progression is one of the priority agendas which we have to do. So the PFS in patients with or without brain metastasis, Ceritinib, 10.7 months in patients with brain mets versus 6.7 months. In patients without brain mets, you can see 26.6 months was the PFS versus 8.3 months. So not only did the patients with baseline brain mets respond, the failure rate in the CNS was also reduced significantly, almost by a significant proportion. So you are almost having a delta of 1.5 years. If you look at intracranial response, 72.7% with Ceritinib as opposed to 27.3% with the chemotherapy arm. So, and in the Asian patient subgroup analysis also, extracranial as well as intracranial response was better with Ceritinib. Now Ceritinib has been compared with chemotherapy, Crizotinib also has been compared with chemotherapy. The new trials for, like for example, Alex or Crown, they have compared, the comparator is Crizotinib. So these two trials are with chemotherapy, the newer trials are with, the Crizotinib. But so this is an indirect comparison which was done, and here you can see 10.9 months was the PFS with Crizotinib, 16.6 months was the PFS with Ceritinib. And if you look at the overall survival, there was no significant difference in both the Crizotinib study as well as the Ceritinib study, probably because of crossover. But ALK-positive tumor probably are the tumors which have the maximum overall survival data, and they even with this crizotinib, in the crizotinib study, you are having almost a 7 to 8 year overall survival. Safety profile, so time to definitive deterioration of quality of life was reduced by ceritinib, and lungs cancer specific symptoms like dyspnea, pain in the chest, and chest discomfort was also significantly improved with ceritinib. So now we talked about toxicity, and practical point is when we give ceritinib, we have to counsel the patient for GI side effects, and we have to actively manage them, and probably have a very short follow-up, probably in a week or 2 weeks when you start the patient on ceritinib, because the GI toxicity is something, the nausea, the vomiting, which is something, and I have had patients who sort of say that we don't want to take the drugs if they have not been counseled. So that is something which requires active management whenever you give ceritinib. So in the ASCENT-4 study, you had nausea, vomiting, diarrhea, and some amount of hepatotoxicity. So liver function tests should also be monitored when the patient is put on ceritinib. And prophylactic antiemetics should be given when the patient is put on ceritinib. So we have a lot of options in ALK-positive NSCLC, and here ceritinib is the panda, but obviously you don't. But you have a lot of options now, and the landscape of advanced ALK-positive NSCLC started with crizotinib, then we moved to second generation TKIs like ceritinib, alectinib, brigatinib, and lorlatinib, and now I think the talk of the town is the updated analysis of the CROWN study and lorlatinib in the first line. But if you look at the NCCN guidelines, preferred options may be alectinib, brigatinib, or lorlatinib, but you do have ceritinib as an option. And essentially, sequencing is one of the options because ALK-positive tumors somewhat, even though we traditionally say that 1/3 of patients in lung cancer do not receive a subsequent line of therapy, but in ALK-positive tumors, potentially there is some scope for sequencing. Also, practically speaking, the cost of treatment MRP-wise is around 50,000 for ceritinib. And practically speaking, ceritinib still remains the most affordable TKI with a good intracranial penetration in Indian setting. That is what is practical, because the compliance and other things also have to be managed, and we have to consider the affordability of our patients. And practically in my patients also, the most accessible and the most affordable ALK inhibitor is ceritinib. And it also has an added advantage of good intracranial efficacy. Sequencing probably may be an option in the Indian setting. Now, points to consider while using ALK inhibitor in the first line: superior efficacy should be there. No brain mets at baseline, so we should prevent the brain metastasis, which again, there was almost around 24 months versus 8 months. That was the difference to prevent the intracranial progression. If there are brain mets at baseline, obviously we use a TKI which can penetrate the blood-brain barrier. Ceritinib does that. Symptomatic disease, we have to use a drug with a very rapid response. And if at all we use a first-line agent, we should also consider what we have to use in the second line. And practically speaking, in my patients who come to me, majority, the first line will be ceritinib, the second line will be chemotherapy, because they will not be affording the subsequent choices. So, and ALK-positive tumors do respond to pemetrexate-based chemotherapy also pretty well. So, I think these are my thoughts. Conclusion. So ALK inhibitor naive patients, ceritinib showed significantly improved PFS, numerically improved OS, but again, the data is not mature. PFS benefit was seen regardless of the presence of brain metastasis. Gastrointestinal adverse events with ceritinib were manageable, and we have to manage them actively. Prophylactic antiemetics should be given, the patient should be counseled. Hepatic functions, liver function tests should be monitored. And efficacy and safety of ceritinib was also established in the Asian patient population with ALK-positive metastatic NSCLC. Thank you.